Hello everyone, my name is Katie Smith, and today I'm going to be discussing major depressive disorder and all of the complexities lying beneath MDD. So to start off, we have the historical background of major depressive disorder. According to class content and other sources of research, major depressive disorder is one of the most common psychiatric disorders and the leading cause of worldwide disability. The history of major depressive disorder dates all the way back to the times of the 1700s through the 1800s. And leading from this, an extensive amount of research regarding this disorder was performed through the 18th through the 20th centuries. Determining what this disorder genuinely was went through a lot of different aspects through different authors. Based on a variety of different sources, major depressive disorder was known as melancholia during these times. Before shifting to major depressive disorder, it was also referred to as manic depressive disorder after melancholia. Through a lot of research and writing, major depressive disorder and the concept of depression was established as an independent mood disorder with characteristic symptoms and signs and a good prognosis by 1880. Moving on to the diagnosis of major depressive disorder, according to our class content and further research conducted, the diagnosis of major depressive disorder requires the presence of a major depressive episode. Major depressive episodes are diagnosed when consistent depressed mood, anhedonia, or hopelessness is present for at least 2 weeks. As discussed in class, it is important to note that a major depressive episode is generally not diagnosed when the same symptoms could be attributed to bereavement, which are normal feelings of sadness after the loss of a loved one. In addition to the diagnosis of a major depressive episode, diagnosis of major depressive disorder also requires 5 of the 9 criteria from the DSM-5 for major depressive disorder to be met. When diagnosing major depressive disorder, the exclusion of substance use disorders and other medical disorders is critical. In terms of diagnosing MDD, there are a variety of different ways one can fulfill this diagnosis. The criteria required to obtain a diagnosis for MDD results in heterogeneity in patients' clinical profile because there are many different possible combinations of criteria that qualify for a diagnosis. This essentially means that individuals suffering from major depressive disorder can meet the criteria in an extensive amount of different ways, sometimes meaning that 2 individuals can have no symptoms in common with one another. Moving on, we have the etiology of major depressive disorder. The etiology behind MDD, in fact behind all mental disorders, has been debated for an extensive period of time. Some people believe the etiology behind major depressive disorder lies beneath a biological foundation. For example, research and meta-analyses display how different pathophysiological mechanisms, such as increased inflammatory responses in the brain, abnormal functioning of the HPA axis, and chemical imbalances all contribute to the etiology of major depressive disorder. Some people believe the etiology lies beneath a psychological foundation. For example, research and studies demonstrate how cognitive distortions and a poor perception and understanding of self can contribute to the development of MDD. Others believe the etiology lies beneath a social foundation. For example, large amounts of research has shown how social factors, such as social risk factors, social impairment, and poor social functioning, is associated with the development of major depressive disorder. However, an emerging and more accepted etiological theory has been recognized, being of which how of all of these biological, psychological, and social factors interplay and interconnect with one another to contribute to the development of major depressive disorder within an individual. A direct quote from one of the scholarly articles I found states, "Epidemiological and neurobiological studies have suggested that interactions between biological factors such as neurotransmitter system dysfunctions and genetic vulnerabilities, psychological factors such as impaired emotion recognition, and social factors such as bullying over time explain the risk of developing MDD." Moving on, we have the treatment of major depressive disorder. So there are numerous different forms of treatment available for individuals who suffer from major depressive disorder. These different forms include medications such as antidepressants, and then a variety of different forms of therapy, including cognitive behavioral therapy, interpersonal psychotherapy, mindfulness-based cognitive therapy, and more. In a sense, medication and evidence-based pharmacological treatments are a default or first-line form of treatment for individuals with MDD. Despite this possible negative connotation behind a default form of treatment, research and meta-analyses have shown the benefits and success behind antidepressants, thus why they are so popular. However, we have discussed in the class the major controversy between Big Pharma and the psychiatric field, thus potentially explaining why these antidepressant medications are so popular. We have discussed how 70% of the people in the DSM task force have relations to Big Pharma somehow, which is a massive conflict of interest issue that needs to be addressed. Moving on from medical treatments, therapeutic treatments have been supported as well. Cognitive behavioral interventions, continuation treatment with either cognitive therapy or interpersonal psychotherapy, preventative cognitive therapy, and mindfulness-based cognitive therapy are all forms of therapy that have been shown to be successful in the treatment of patients with major depressive disorder, as well as assisting them in avoiding relapse. Moving on, we have the prognosis of major depressive disorder. So, partially due to the presence of a major depressive episode needing to be present for the diagnosis of MDD, MDD is typically viewed as a more episodic and isolated disorder, leading to a more positive outlook on its prognosis. However, research has shown that this is not the case, and that major depressive disorder is a more chronic and recurrent disorder that is disabling. Thus, individuals that suffer from major depressive disorder tend to have a discouraging prognosis. There are many factors that come with the prognosis of MDD. For example, individuals that suffer from MDD can have a major depressive episode that lasts 6 to 12 months if they go untreated. In addition, out of the individuals who suffer from major depressive disorder, approximately 2/3 of them consider suicide, and 10 to 15% of them actually commit suicide. As a part of its prognosis, major depressive disorder also has a fairly high recurrence rate. The recurrence rate is about 50% after the first episode, 70% after the second episode, and 90% after the third episode. Continuing, major depressive disorder has a tendency to be comorbid with other mental disorders. Thus, approximately 5 to 10% of individuals with MDD will eventually also receive a bipolar disorder diagnosis. Lastly, the prognosis of major depressive disorder can differ based on certain aspects. For example, individuals with MDD can have a more favorable prognosis if they possess mild episodes, the absence of psychotic symptoms, better treatment compliance, a strong support system, and good premorbid functioning. They can have a less favorable prognosis if they possess a comorbid psychiatric disorder, personality disorder, multiple hospitalizations, and advanced age of onset. Lastly, we're going to move into the biblical perspective of major depressive disorder. So the concept of MDD, or any mental disorder for that matter, within a biblical perspective has been a major topic of debate for quite some time. Some Christians and individuals argue that mental illness solely comes from sin and not having a proper Christian life nor a relationship with God. Others disagree with this claim. However, research and findings have displayed how believing that mental illness solely stems from things such as sin and faith disturbances is harmful and can enhance mental illness problems within individuals. Apart from this, another aspect of MDD within a biblical perspective is how religion, specifically Christianity, impacts individuals with major depressive disorder and the course of it within these individuals. An extensive amount of research has shown positive relationships between strong religious beliefs and reduced symptoms of MDD and depression. In a study conducted, almost half of the participants reported at least one noteworthy association between religion and spirituality in a more positive course of depression. Along with this, a large proportion of the participants communicated how when they were dealing with a religious struggle, they were also dealing with a notable amount of more depression. A more intricate aspect of this concept is how research has found that belief in divine forgiveness correlates with better psychological well-being and lower rates of depression. Lastly, research has also shown how stronger religious and spiritual foundations and beliefs lead to better treatment responses within individuals who suffer from major depressive disorder and depression. So ending the presentation, I have an interview with an expert on major depressive disorder, going over some of the topics that have been covered in this presentation. Okay, hi Ms. Sales, thank you so much for taking the time to speak with me today. This is going to be super short. I'm just going to be asking you a few questions about major depressive disorder. So my first question is, what is your opinion on the debate of the etiology of major depressive disorder?
Good question. Got my books out.
Yeah.
So tell me a little bit about which controversial.
Yeah, sure. Honestly, I'm kind of more pertaining to, because I know there's been a lot of debate whether major depressive disorder has any biological basis and stuff like that, and whether it's because there's a lot of theories about how it's a mix of all of the different dimensions, but I think there's still debate whether or not chemical imbalances in the brain and more biological factors have any contribution to it. So I was wondering what you think about that.
Gotcha. Yeah, I think with a lot of different disorders in the DSM that are diagnosable, it's so hard to say just with where research is at right now.
Yeah.
I know following some of the more kind of brain studies and that biological component, they're learning more every day about it, which is really cool. And, even within ThriveWorks, I know our psychiatry department does actual testing to see which medications work best for certain people's genetics. And so I think that's an amazing kind of progress for where we're at just in the past few years.
Yeah, for sure.
But with every single disorder, I think there's an element to nature versus nurture within that, and how we're raised, and our environment, and our biology.
Yeah.
And I think depression is tricky because there can be different reasons people are experiencing symptoms of depression.
Yeah.
It can be situational depression, a lot of things going on all at once that kind of cause us to start experiencing symptoms. Versus, there's not a whole lot going on, and for some people, it's just popping up every day.
Yeah.
And so it's really hard to say without specific testing.
Yeah. For sure.
Yeah. It's a definitely interesting, and I just think it's person by person.
Agreed. Yeah, I definitely agree with that. It's definitely tricky for sure. So my next question is, with your experience over the years, would you say that major depressive disorder is easy to diagnose?
I would say yes. Out of all the different disorders in the DSM, yes, I've gotten kind of pretty efficient at seeing some of the symptoms and signs and being able to really see how it affects people's lives, and if it is a contributing factor to kind of disruption in their everyday lives. And so, of course, there's clusters of symptoms that you can experience with other disorders. And so it's really about being thorough and doing our biopsychosocial interviews upon admission and kind of keeping up with getting to know the client so that we can see some of the things that we might not see initially.
Yeah.
And kind of reassess as we keep going and keep moving forward. So I wouldn't say it's the hardest thing to do, part of my therapy hat.
Yeah.
But it still is tricky, and it still is really important to make sure that it's a client-by-client, patient-by-patient basis in doing our assessments.
Yeah, 100%. And then my last question is, what do you think are the best forms of treatment for individuals who suffer from major depressive disorder?
Sure. So I am a huge proponent for behavioral interventions.
Yeah.
And so I love a mindfulness-based intervention, whether it's paired with CBT or DBT skills. So my go-to is a little bit of CBT, cognitive behavioral therapy, to address kind of what are the thoughts. And again, it is a client-by-client basis. I like to kind of figure out what is really this person struggling with most, what are the specific symptoms that are affecting this one client the most, and then I kind of go from there to tailor what the treatment may be.
Yeah.
Cognitive behavioral therapy is incredibly effective. It is figuring out where it's starting, kind of chain analysis.
Yeah.
Is it the thoughts? Is the emotion coming on? And then it's about, trying to help people then change that kind of pattern of behavior.
Yeah, I love that you talked about CBT. Sorry. No, go ahead, keep going.
No. Mindfulness as well, I think, is a wonderful treatment for so many different disorders. And I think it can be really helpful for depression because it allows the person to have more control over their focus and their awareness. And so when they can say, okay, I can see those thoughts happening and let me pull myself back into the present moment so that person isn't constantly kind of looking at the shoulda, coulda, wouldas and the past and all of that can kind of bring on more symptoms of depression.
Yeah, 100%. I love that you brought up CBT because we've talked about cognitive behavioral therapy so much in this course, and just how it's been shown to be fairly effective in a lot of different disorders. So I know that it's a very popular form of treatment. So I'm glad that you mentioned on that.
Yes, I love it. And I love DBT for particular populations. Depression, there's certain skills in dialectical behavioral therapy that can be helpful for anyone and anything. But I would say primarily cognitive behavioral therapy and a lot of mindfulness-based treatments for depression.
Yeah. Well, those are all my questions for you today. Thank you so much again for taking the time to speak with me, and thank you for your information, and So this has been the end of my presentation. Here's my credit slide. Creator is me, Katie Smith. The individual I interviewed, her name was Catherine Sales, and this video was made within the context of the Abnormal Psychology course, which is PSY 350 at Anderson University. Here are my references for the pictures in the presentation. And then these are the references for the scholarly articles that helped me with this presentation. Thank you so much, and